Hey everyone, welcome to the Powered by Iron Health podcast. I'm Joe. This is Dr. Fern, our director in our Peak Skill office, special guest today. We have a special topic we're going to be talking about. Today we're going to take an athlete who has an injury and really go through his whole injury, what happened, protocol for PT, and how you manage it. And that's Cam Scatteboo, right? That's his name.
Cam Scatteboo. All right, let's start it off. So I'm going to start this off by saying, go Giants, go blue. Number 44, favorite number here. So a couple weeks ago, Cam Scatteboo had an injury, right? He was playing against the Eagles. And, the unfortunate event of him falling to the ground and hurting his ankle. Now, the mechanism of injury was insane looking at it, watching film. Did you get a chance to take a look at it?
Actually, I didn't look at it.
It was pretty crazy. I mean, if you could imagine your foot just being turned this way and then everted that way, and then just a 250-pound man just crushing it, just destroy the ankle completely.
Crazy.
So we were looking at, looking at what happened. It was a fibular fracture. It was a deltoid ligament tear complete. Also, some kind of damage to the tendon as well. So they didn't specify what tendon was. I'm thinking either peroneals or posterior tib, most likely peroneals. So dislocation of the talus, fracture of the fibula, tear of the deltoid ligament, and some kind of peroneal or posterior tib tendon tear there. He's a running back.
Yeah.
What's going to happen? What do you think is going to happen?
That's going to be a pretty extensive rehab to get him back to normal because it's a blowout. It's like you see people blow out their knees, but their ankles is a lot rare.
Absolutely.
I mean, and just talking about the mechanism, just to kind of bring it down, like his foot was turned out and someone came and hit him from the outside,
Yes.
right? And that's
It
what
was it
happened.
was one of the situations where the foot was turned out, he was rotated this way, and if you could imagine the foot, you ever see a kid sit in W position?
Yep.
He was in a W position as his foot was turned out and everted, and the man landed on him that way. So that force downwards, not only the force was so great, but the rate of that force was so insane that the tissue just couldn't hold on to it. So with that being said, I mean, the nature of him playing, he's a power running back at 5'11", 215 pounds. He runs between the tackles, and he's got speed, but it's not his main game. He's meant to be a power back. So, like, thinking about the way he runs now, do you think that it's going to have to change moving forward as he develops and he gets back into a playing shape?
Well, what are they saying as far as timeline for him?
Well, they say that within a year is what they're hopeful for. They said there was no, cartilaginous damage there, which I'm not exactly sure what that means in terms of the hyaline cartilage, is it the articular surfaces they're talking about there? But they're saying within a year he should be good to play. But we all know that, with a complex injury like that, having tendons, having ligaments, having bone fractures, that, the timelines become a little wishy-washy. And with that being said, like, what does initial PT, what would that look like for like an elite athlete like that?
Yeah. Before we jump to the PT, let's describe the cartilage defects to people because the people might not know what hyaline cartilage
Right.
is or articular cartilage.
Mm-hmm.
I think saying that's actually a good sign that that wasn't if nothing was done
Yeah.
there because that could be a lot longer of a rehab.
Absolutely. Yeah, yeah. So if we don't have that cartilage or that support between the bones that way, then that ends up being some form of arthritis, right? And so him being a younger athlete, being a rookie this year, that's a positive thing for him as well, because if he doesn't have that kind of arthritic changes this early on or anything that might cause that in the future, then he has longer time to play, right? And so it ends up being all about bone and tissue healing times. We know that bone healing times between 6 to 12 weeks, and soft tissue could be anywhere between 4 to 12 weeks, depending on the nature of the injury and severity or grades of the injury. If it's a complete tear, a slight tear, there's a whole sliding scale for that as well. So, knowing that he doesn't have cartilaginous or articular damage there gives him a better, a longer shelf life, if you will, in the NFL, especially as a running back, which we know they have short
It's
lives
short,
there.
especially
Yeah.
the way he
Yeah.
runs,
Oh,
right? Like
absolutely. I would
that's
have thought
old
it would have been
school.
CTE that would have got him out, even after his first year. But it's definitely looking like his ankle this time around. So
Now, what are they doing as far as is it surgical?
it's surgical. It was
So
it was. I believe it was placed back. The talus was completely dislocated, so it had to be relocated. So had to get surgery off the bat there. In terms of the fibula, what they did with it, I'm not too sure. I'm assuming they're just bracing it up, and just going non weight bearing for 6 to 12 weeks.
okay, so if we don't have a plate on the fibula, is there one on the talus? So that like, what are they doing with the talus?
That's a good question. I don't think they released that kind of information yet. You're seeing him on social media, right? We just talked about is there a plate in there, or what's going on in general in terms of his care right now? Well, we just saw him in WWE just playing a little stunt there, pushing people back and forth. He's obviously weight bearing if he's pushing someone off, and he's on Twitch streaming, so he's keeping his brand alive. So I'm assuming he's doing okay right now,
Yeah.
right? At least initially. We don't know what he's like with range of motion or strength wise, but he's out, he's walking. So
Yeah, I don't even know if he's in a boot. Is he in a boot?
I saw him in crutches. I
Okay.
know that. I did see a couple of social media posts of him on Twitch where he's telling his viewers, "Hey, look at my ankle," and he's moving his ankle up and down. So he's got active dorsiflexion and plantar flexion already, so that's a good sign. He had it wrapped up. I couldn't tell if it was a casted or if it was just wrapped up. So I'm not exactly sure, but he's weight bearing. That's all I
Interesting.
know. Yeah.
Yeah. Because when I think about it too, like an ankle injury, the deltoid ligament, to actually tear the deltoid ligament.
You don't hear a lot
Yeah.
about that. You hear the ATFL, which is the ligament that's on the outside of your foot that decreases the risk of you like rolling your ankle inwards. That's the typical injury we typically see in physical therapy is an inversion ankle sprain or the rolling of the ankle as the ATFL gets impacted. But for the deltoid ligament, we don't see that typically. It has to be some wildly blunt trauma or some misstep with such high force for that to happen. And like I said, I haven't seen that before.
I've seen one,
Hmm.
and when I think of this person wasn't a high level athlete, but she was doing a box step up,
Hmm.
and she came down the wrong way, and she had a sprain eversion,
Uh-huh.
and it wasn't even fully torn. And when she came to me, she had like pinching in the anterior
Right.
aspect of the ankle,
Hmm.
not full range of motion,
Right.
like all these things. And she stopped PT really early, and I don't know how she's doing now, but she definitely did not get back to full function.
Right. Of
Now
course.
she wasn't a high level athlete, right? So
Yeah.
she doesn't have the capabilities that someone like he does, but just seeing from a normal person, that's such a strenuous
Oh, absolutely.
sprain or tear, if it's fully torn.
He's got that going on. He looks like he's doing pretty well. And then when we're talking about the rehab thing, obviously, rehab for an elite athlete looks a lot different than rehab for the layman, depending on the nature of the individual as well, right? So initially, it's going to look the same, right? I would assume just looking on, making sure the ankle can move up and down, left and right, and it has the adequate strength to stabilize. That's across the board what we need. But how would you think this would change along the board as he starts developing and getting ready to take that next step? What would be the difference between the PT for the layman and then the PT for, let's just say, an elite running back?
Yeah, I think the biggest part when you think of someone who's a professional athlete is the frequency they get,
Right.
right? There's no way that he's not doing PT every single day. And
Absolutely.
and I'm talking strenuous PT where it's hands-on,
Hmm.
tissue work, intense mobility
Right.
if it's allowed within his
Of
protocol.
course.
And then really working on basic strength and
But are
stability.
you thinking he's going to like, the run of a mill kind of clinic, or is he going to have like individualized
Oh,
care?
100% individualized.
Right. Absolutely.
They have a team for the Giants that just is like designated to rehab these athletes,
Right.
right? So
Right.
it's like the individualized attention he's going to get is going to be tremendously different from a normal
Right.
person.
Of course.
Think about
Absolutely.
when I think about an athlete, the one who always comes to mind is Adrian Peterson when he tore his
Hmm.
ACL,
Oh, double
right?
ACLs there, and then what? He had that 2,000 yard season
Yeah,
the year
he came
afterwards.
back in 6 months, right?
Hmm.
So like maybe he's just a freak, or like a freak compounded with the ability to have
Right.
extreme quality care,
Absolutely.
right? Like
Yeah.
someone like, hey, you're an extreme athlete. You cannot rehab like a normal person.
Absolutely.
You have to take it to the next
Yeah,
level.
yeah. That's a good point to say, like, that the rehab will be a lot different for this individual. Obviously, they have a lot more resources, but let's just say a layman wants to go ahead and have those same treatment styles there. Iron Health offers one-on-one. We offer one-on-one care as well, so that's something that we could definitely like think about too as we're getting these athletes coming in here. It's like if they have these complex injuries, it's like you don't have to worry about getting the most professional care, going to the Giants, physical therapist. We have care here in our local areas between Stanford, PK, Ardsley, and Briarcliff. We have all those people there too that we can take care of. And I just wanted to take a note in terms of like the one-on-one care as opposed to the mills we have out there as well, and just making sure that everyone knows that there's a difference between the two, right? And making sure that we have adequate care and people know that when they come in here and they see us or they see the individuals with the one-on-one care, it becomes so much more about the quality and excellence. Obviously, getting back to a running back in the Giants, right, as opposed to being an individual who wants to be a marathon runner, it could be one and the same if you think about it, but it shouldn't take away from the clinical care that we give to people, whether it be professionally or just a layman coming to the streets there. So, it's cool that we do that.
Yeah, I 100% agree. I mean, it's a very rare thing, and I think that starts with, any sort of rehab care, right?
Hmm.
And even looking at Cam, is the mindset, right? Like, what is your mindset going into an injury? Are you trying to get back to just walking? Because
Right.
that's a totally different goal than if you're like, hey, I want to get back to running and sprinting and
Absolutely.
understanding and doing things that I love to do.
Hmm.
And you need to align yourself with someone who's going to be able to get you there versus someone who's like, hey, your range of motion is good, your strength is good, go ahead, get on your own. Anyone who suffers an injury, that's probably the base level, right? Understanding the mindset first.
I'd say so. I mean, you're not going to be the same person walking in, but you're going to be go ahead and be a new person as you walk out, right? So if you go into rehab or you go into an injury under the assumption that, you are less than, right, and that you aren't going to be what you're going to be able to do afterwards, then it's going to mess with you, right? If we're able to go ahead and have insights and have our idea of what the ideal situation or outcome is going to be, or what is the ideal goal for the individual, right? If they have a goal, can we go ahead and make sure that everything that we're doing aligns with that individual as well, so they see the tangible progress? And because I can only imagine being an NFL football player, being a rookie in the league, and having a kick-ass year. You have 4 touchdowns in the season already. You have 400 yards, right? You're hanging out with the bro Jackson Dart, right? Doing all these celebrations here, and then you're out for the season, right? With this devastating injury, right? You have to be in that mindset of wanting to win and wanting to come back better than ever, right? And it's that mindset that separates having, you know, an okay outcome from having a great outcome. And Adrian Peterson from another individual, it's
For
just
sure.
having that tenacity.
So with his rehab, let's talk specific of
Hmm.
how people understand what a flow of an ankle injury like that looks
Right.
like. Phase one, right? He
Yeah.
comes out of surgery. What are they doing, or what is the normal person who has
Yeah.
even an ankle break? Like, what is the initial phases that you
Yeah.
think he's starting with? And
So,
how far out of surgery is he now?
oh man, it has to be a couple weeks from now. I
Two,
can't give
three
you the
weeks.
exact, a couple weeks from now
Yeah.
here. So initially, so stage one will be more so depending on the nature of the injury and nature of the surgical procedure, right? Whether he's going to be in a boot or not, right? Is he weight bearing? Is he non weight bearing? That changes a lot of things for him, right? So if he is partial weight bearing, meaning he has a cam boot, no pun intended,
Yeah.
a cam boot, he's able to walk with crutches and bear weight limited, right? With that being said, now he's getting the ability to tolerate load through that extremity, which is already a great thing. The faster we could tolerate load or have our weight on our foot, the better the outcomes. We know that that's exactly why knee replacements, hip replacements have to stand and walk right immediately after surgery, right? So he's already weight bearing. We know that already, right? The next phase would be within stage one would be weight bearing or range of motion work, being able to actively move the ankle up, down, left, and right, being able to weight bear, being able to navigate or ambulate, right? And then we go on from there depending on the levels of impairment. Can he ambulate? Can he go upstairs? Can he transfer? Is he able to go ahead and sidestep if he has to, right? Can he really navigate the terrain or obstacles that's in front of him right now that's currently in impairment? Can he walk on even grounds, right? When you have a cam boot and you're walking on even grounds, like cam boot stiff, man, it doesn't give you much malleability, so you have to kind of like assert a certain position to be able to navigate those terrains as well. So that's his phase. First phase is just getting range of motion back, getting some activation of the muscles, and being able to weight bear, walk appropriately, and transfer into in and out of positions that you could just deal out in activities of daily life.
What is some of the things people do to get range of motion back? Like, what are the modalities or interventions we
Yeah,
can?
yeah. So I mean, every place is going to be different, right? And I like to say, like, if we could make it active as possible, meaning, have the individual be a part of it, that'd be great. Now, I'm okay initially doing some passive range of motion, meaning when the therapist grabs the foot and bends the ankle backwards and forwards, side to side within the limitation, because it could be within protocol, right? So the professional needs to be able to see how far can we bend and what are the parameters between the degrees we could do, right? So that would be one way, the passive range of motion of the therapist. Another way could be self-mobilization. The patient themselves can go ahead and grab onto their foot and mobilizing, so long as they're taught appropriately, right? Then it goes on to different modalities in terms of like how we start influencing that during our exercises in the later stages. So I know we're not there yet, but like I say, mid stage, we could easily get more dorsiflexion by having heels elevated squats, right? That's an easy passive way to go ahead and get that squat in there, but also work on dorsiflexion. Another way you can work on things is working on like a plank, right? You're on your plank, your feet on the ground that way. If we have the stability to do so, we can work on that lengthening of the Achilles tendon and the dorsiflexion as well. That's another way we could work on it. So there's so many avenues we have to take and take account for, but it depends on the level of the injury, the individual we're taken care of, and also where they're at in that stage, whether it be early or mid to early, it just depends.
Yeah, I've seen too in my career, seeing a lot of ankle injuries, dorsiflexion, which is the ability to move up, is the
Hmm.
hardest one to get back,
Yeah,
right?
absolutely.
Now, I've seen different levels of how aggressive you have to be with manual techniques too,
Hmm.
right? Would you
Yeah.
agree that someone like a Cam is probably getting a lot of
Oh,
hands-on
heck yeah,
eh,
heck yeah.
to make
So
sure we're
he's
pushing that?
he's getting soft tissue, the gastrocs, the soleus, the back of the foot, the back of the calf, right? He's getting soft tissue there, right there, the side of the legs, the peroneals, the fibularis, the posterior tibs. He's getting all those soft tissues works, right? And then he's going to go ahead and be mobilized afterwards, whether it be passively by the therapist or himself going through like a half kneeling dorsiflexion mobility. They're getting soft tissue, and it could be cupping as well. Cupping, it could be dry needling. It could be, any form of acupuncture as well, just to get the most out of that. And they have the resources, so why not?
Yeah,
We typically prime the tissue first through soft tissue mobilization or some kind of modality like that. Then with that newfound range of motion or the ability or that decreased tone of the neuromuscular system, now we're able to get more range of motion that way. So they're probably facilitating that with soft tissue, then range of motion to get the most out of their sessions every day.
for sure. And they're probably doing a lot of that in phase one,
Oh,
really,
absolutely.
decreasing inflammation, making sure range of motion comes back, especially if he does have a plate in there, right?
Hmm.
Like it's going
Yeah,
to be limited. And I've seen times too where people have plates and they have to get them removed, which is an interesting
that's
one.
wild.
Yeah,
Did you
like
start from the get go again, like stability wise, range of motion wise? Like it's a different kind of trauma too, right?
you're not going to base one, but
Right,
you're reverting back.
right, right.
It's another surgery, right? I mean, they're removing it, your bone's healed, but range of motion is definitely gonna be limited. There's
Yeah,
gonna be more scar tissue because you're
absolutely.
reopening it up. But sometimes those plates can really restrict range of motion, or sometimes the pins get loose. Like
Yeah,
it's
of
crazy
course.
what can happen. And I'm sure someone at his level has like awesome surgeons too
Yeah.
that are monitoring that very
Mhm.
closely, right? So kind of that's really the phase one. When we get into the next phase, what is the expectations there? And I would say these phases too, just for everyone listening, like they're yes, this is an intense injury, but this is
Mhm.
anyone with even a basic ankle sprain. You still have to go through these
Yeah,
steps to get
absolutely.
where you want to go,
It
right?
ends up being like a spectrum as well. Like regardless of what the injury is, like Joe was alluding to, we still have to hit the base parameters, range of motion, stability, strength, all those things. It just, depending on the individual, it just ends up being the modality or the way we end up giving or prescribing exercises might be a little more advanced, meaning the loading or the techniques we're utilizing might be a little more advanced or it might be a little regressed, right? But no matter what, we're dealing with impairments. And the impairments, what we see is going to be range of motion, stability, strength, and functional activities, right? So as we tear away from phase one being just range of motion, the activation of the ankle, and being able to tolerate activities of daily life, meaning like being able to get off the toilet and maybe go up and down the stairs, right? The next phase would be like really making sure that we're strengthening both extremities, but decreasing the discrepancy between the injured area and the non-injured area, right? So we're looking at our squats, our hinges, a form of lunge, a step up, and then going out and loading those up and seeing if we could find any changes or shifts or whatever the case may be, and then narrowing down on the unilateral movements or one-sided movements to go ahead and decrease the discrepancy of strength between both left and right sides. Because if you think about it, if an individual isn't strengthened appropriately, right, and they have some kind of discrepancy in both left and right side, as they're accelerating and running, what is that going to look like? A pretty nasty limp, right? Which could set you up for another injury down the road. So making sure strength is intact bilaterally and more importantly, unilaterally is going to be the next phase. And like I said, it's going to be most likely those foundational motions. Now, the degree of the load and the technique, whether it be like rear leg elevated split squats as opposed to like a forward lunge or a forward elevated lunge, that depends on the nature of the ability of that person or that patient we're seeing, and then also the expertise of the physical therapist.
Yeah, that's really well said. And I think that's, if we had to summarize that, that's like the foundation of strength, like really
Yeah.
developing unilateral strength again,
Hmm.
understanding how the body moves in a functional aspect is going to be
Absolutely.
key, right? And during this phase, like what are some guidelines you look at for progression to the next phase or regression at that point?
Yeah, yeah, absolutely. So, I mean, it starts up. I'm a big fan of making sure we have a nice stable base, right? So, proximal hips, can we do hip flexion, hip abduction, glute stabilization, pelvic stabilization, right? And not only laying down position would be probably more so like phase 1, but also stage 2 or phase 2 as we're standing up. Are we doing banded marches? Can we do our side steps? Or even if we want to elevate it a bit more, can we do a side plank with hip abduction, right? And we have adequate control of the pelvis and the hip as it's going up and down that way. We need to have a nice stable core and hips to make sure we could tolerate the foundation of movement, right? What's the point of loading up on an unstable base? That'd be stupid, right? So first and foremost, let's make sure the hips are taken care of. And we're taking care of that in phase 1 and just progressing in phase 2, right? The hips are taken care of, then we're progressing into our foundational movements. We all got to be able to use the bathroom. We all got to be able to, get off the toilet. So squat, right? We go into a squat, and at that point, we start really assessing down the chain from low back, hips, knees, and ankles. How's it going? Is the ankle range of motion still limitations? If so, how is that being seen in the squat mechanics? And then from there, it becomes just a tree of where we could branch out of, right? If we're seeing a discrepancy in squats and we're seeing an individual lean to the left side as opposed to the right side, right? Is there a limitation in hip range of motion, knee range of motion, ankle range of motion? Is an apprehension? There's so many different ways you could attack it, but it's really up to the therapist and patient and their combined ability to communicate to be able to really diagnose what's going on. And that's how we go ahead and go through each foundational motion from squat to hinge to lunge to step up or whatever the case may be. What they might need down the road is how we go and address it.
I think it's a very good educational point because a lot of people think like, hey, my injury's on my ankle. Why are we looking up the chain?
Right,
But it's like
absolutely.
you have to look at everything to make sure your body's functioning correctly, right?
Absolutely.
If we're only addressing the one area of injury without looking at everything else, when you go to the next phase, it's going to show up
Absolutely.
10 times worse, right?
Absolutely. We've all heard stories of individuals with, like, let's just say like a bum knee saying their low back is hurting, right? But their low back's hurting, but the knee is the one that's the issue, right? Or maybe it's the inability to tolerate being on your feet for that long and taking that impact at the knees, and we're noticing that when we're working on eccentric squats with like a decent load, you're unable to keep yourself steady and you're falling like a sack of potatoes, right? So like these are ways we can go ahead and find out what's really going on, what's the real issue, as opposed to like what is the problem area telling you, right? Because oftentimes we feel pain, but is the pain coming from there or is it coming from somewhere else? And that's exactly why, as a physical therapist, looking above and below the joint and as a person holistically is so much more important than just what's on the prescription and what's your pain right
For
now,
sure.
right?
What's your steps when you're looking at someone in this stage 2, to be like, all right, we can now bring it to stage 3?
Right, right. You always hear us say it depends, right? As a physical therapist, it all depends, right? It depends on their previous capacity, their function before the injury happened, right? So let's just say we have an athlete like Cam Scatteboo, right? So he's most likely squatting in the 400s, right? He's deadlifting in those ranges as well. He could probably do a pistol squat. I'm just giving theoreticals right now, right? But the idea would be, let's get him back to power level of function, or at least 80 to 90% close to that to be able to progress that way. So we're looking at that first, right? So adequate squat, right? Adequate lunge, hinge, and a step up, right? We're looking at those foundational movements. Are there degradations down the chain? If there's no degradation and we can increase load to, moderate to heavy loads and there's no breakdown in tissue or technique, all right, we're able to do so. Now it's time to go ahead and see, can we tolerate even higher loads body weight wise? This becomes your snap downs, your introduction to plyometrics, right? Because at the end of the day, it's all about ground reaction forces and being able to tolerate that, pushing into the floor so the floor pushes back to you so you can run linearly, horizontally, or you jump in the air vertically, right? It's all about producing forces. And can we tolerate those forces without breaking down or other tissues being impacted by it?
Yeah, I think that those are all good points. Like you kind of, and that's something to know. Like all PTs, we have in the back of our mind like a repertoire of what we need to be hitting to take it to the next level. I use a lot of tests from like the FMS too. Like I'll look at like a anterior reach to see that there's stability side to side, overhead squat. I do think step downs and step ups is something that's shows so much. You can have anyone who just even has a little knee pain, put them on a step down, and
Or
it
the
shows what's
crazier
going
thing
on.
too, I had a patient and I was doing a step down test and he was great, but he was talking about knee and Achilles pain. I'm like, you're doing great, body weight wise, and we're even increasing the height of the stair. But the moment you add load, right, they start breaking down. And so that makes sense as why they're running. They have 6 to 8 times their body weight out there. Now it starts to break down. So those tests are just as important as well, just making sure we could dial it down and see what the next step is after that. Because sometimes you don't know until you test it. And even if you test it, maybe you need to test it just a tiny bit more.
Yeah. For that individual, and this is a good kind of learning point, he passed the step down test. Would you jump him?
Would I jump him?
Would you do the plyometrics?
No, I wouldn't. I wouldn't jump him just yet because yes, he could tolerate his own body weight, but as we're running or when jumping or doing any kind of athletic activity, we're going anywhere between 4 to 8 times your body weight with just ground reaction forces. And if we can't tolerate external force with a step down, meaning 20 to 30 pounds, then you can't tolerate 6 to 8 times your body weight with that impact. You're going to end up exacerbating your symptoms. So that wouldn't be appropriate at that time. Would there be maybe possibly an increase? There'll be an increase in load with time to be able to better tolerate that step down test and then maybe move into a snap down where he's not quite leaving the ground just yet, but being able to really get the eccentric forces down, the like stretch shortening cycle part of it, right? Just snapping down that way to be able to tolerate globally lower extremity, sure, but I wouldn't have him straight jump up in the air as high as he can and land, especially if he doesn't have those mechanics down just yet.
For sure, I agree, and I think that's a really good point. Back to your point about it depends, right? Like
Yeah.
always, every person's different. Every single person can have like pain with something and not with something else, or dysfunction show up under load, and that's when we really start to get to the plyometrics level.
Absolutely.
I do like the snap downs. What other plyometrics? And they could scam Catabu or Scatterboo, or anyone else with an ankle injury. Like, what are some other plyometrics that they're going to be expecting in their protocol?
Yeah. So it depends on the quality of the therapist, right? Do they have experience with strength and conditioning, and also are they all performance coaches in themselves, right? So making sure working on stiff ankle pogos.
What's a pogo?
A pogo is 2 feet. We call it a bunny hop too. It's just 2 feet jumping up and down. You either do it in place initially or start working in a horizontal plane as well. And that's more so getting used to the ground reaction forces and the Achilles stiffness that we need to really start to build in order to get those elastic reactions from the ground. The stretch shortening cycle is really important. So starting off with pogos and being able to tolerate that first is the first step. So it'll be pogos first, right? And then, it might not even be pogos on the ground just yet. It could just be a band around the rogue squat rack to help decrease the amount of force hitting on the ground. So you're doing pogos with a band, right? Initially just basically almost weightless there. So depending where you're at, some kind of pogo, right? Then we start doing pogos forwards, maybe a side shuffle, just different ways to get some kind of stimulus, right? In all directions, forward, backwards, sideways, right? So for me at least, the way I like to go for like intro to, like I have an Achilles reconstruction right now, right? And he's about 14, 15 weeks. He's an ex-NFL athlete, so already different animal, right? Different individual. So he's already healing at a different rate. So at this point right now, we're doing pogos down the length of the turf. He's going into single leg pogos, he's going to side shuffles, back pedals, all with the idea of loading the Achilles tendon and making sure his foot is going through all the ranges of motion. He's then going into A skips, B skips, he's going into maybe some skier jumps, jumping side to side, landing and stabilizing, and then we end up doing some form of broad jump, right? And at this point it becomes whatever is tolerant and what we see professionally, right? So 50% of what your max broad jump would be. Let's take a look at that. How are you feeling when you're landing? With that being said, okay, maybe we could push to 75. And then vertical or counter movement jumps there. Now he injured his ankle or his Achilles doing a vertical jump into a sprint. So a vertical displacement force to a horizontal displacement force right here. We've been doing horizontal to vertical. We're not quite there for vertical to horizontal just yet, but we're looking towards that because ideally you want to be able to, get back to where you were before and without being apprehensive. So it ends up depending on the individual, like we're saying, and what their current abilities are, will dictate the plyometric or the next progression, right?
Great. And I think after that plyometrics, then we get into return to sport.
Yes.
So what do those two phases kind of look like, and what's the next level of like a dude like that or Cam? Like how does he go into return to sport?
Right. So we'll talk about just initially phase one. It'll be range of motion, right? Activation of the ankle and being able to tolerate activities of daily living, right? Just being able to use the bathroom and go up and down the stairs. Okay. Phase two, we're talking about bilateral or both leg strengthening, global strengthening of the lower extremities, conditioning back again, and then decreasing discrepancies between left and right side, and then the introduction or the beginnings of plyometrics, whether it be the pogos, the broad jumps, or the whatever the case may be, right? So it's in that between phase between the stage 2 and the late stage phase where we start really melding things together, where it really truly becomes strength and conditioning, right? And so like an early phase 3 might be building the brakes on an individual, right? Because you can't start running if you don't know how to stop, right? So are we able to tolerate eccentric forces? And this could look like rear leg elevated split squat with a kettlebell dropping down and essentially stopping, right? And abruptly stopping on the ground to make sure we could tolerate those forces that way. And it could be done a whole slew of ways, right? But really, can we build the brakes to be able to stop when we're starting to accelerate? Because what's the point of accelerating if you can't stop? Right, you just set yourself up for another injury. So build the brakes. We build the brakes through some form of acceleration, deceleration training in both the sagittal and transverse and horizontal planes, and we're working all different planes of motions, right? So forward, backward, side to side, and diagonal, right? Stop and go. The next one is producing force within a short period of time. So rate of force development, which ends up being acceleration, right? So can we produce this force quickly? And this could look like, as easy as can we do a 5 to 10 yard fly, right, within, our current capacity? Or can we go ahead and with this heavy weight we have right now, can we lift this as fast as we can within safe measures right now? And so it really depends on the athlete and what they're trying to get back into, but the idea is, can we produce force? Can we produce it quickly? And can we stop said force, momentum, or impulse, right? So it becomes basically physics at that point, right?
For sure.
And that's how we move forward. And then it just ends up being just progressing bit by bit, depending on how they present each day, day in and day out.
Yeah, and that's a lot of data for people to understand the full rehab of anyone with an ankle sprain. Now, one thing that I've been thinking about and understand, obviously this is an elite athlete. What do you think are certain things that they may be doing that are also auxiliary to just a traditional physical therapy?
Oh man, you know they're going into their cold plunges, right? You know they're going through their saunas, they're getting their acupuncture, they're getting their soft tissue massage or massage in general. They're getting their NMES, their STEM as well. They're getting a whole slew of things that they have the time for because one, it's their job, and two, they have the resources for it, right? So you name it, they have it pretty much, right? And you can imagine like a spa having the hot and cold baths. You know they're doing that. You know they're getting the cold plunge. You know they're decreasing any way they can decrease inflammation and swelling before and after a physical therapy session to prep them up for the next session. They're already doing it. They're already thinking about it, and it's already done, right? I watched this TV show. It was on Netflix, the quarterback show. You ever watch that show? Right? And you get to see how these quarterbacks live and how they recover from session to session, especially as like they get older. Like Kirk Cousins, he's an older quarterback, and he's before and after practice, he's hitting the cold plunge right now, right? He's just getting his body prepped up and ready to recover for the next week or the next game. And so we know for a fact that they're definitely doing that
For sure.
during
They're
sessions.
probably doing like peptides and stuff
Oh,
too. That's a whole nother
absolutely.
level.
Oh, absolutely.
So, there's levels to it. And obviously, if you're an individual who has any goal to be better than what you were pre-injury, like you need to be mindset, you need to align yourself with the right people and understand what it's going to take to get to that level, right? This was just a masterclass in rehab for ankle injuries. So rewatch it if you have an ankle injury because Fern really dove deep into what it's going to take for you to get back to that level. So I appreciate that. Any final closing remarks here?
No, I mean, if you do go ahead and get an injury, I know it's not on purpose, right? Just make sure you get quality care. Make sure you seek out people that know what they're doing and they care about you, your recovery, and that you're not just a number, right? And one thing I have to say is being a part of Iron Health is being a part of that one-on-one scenario where we're seeing patients one-on-one, having those 40 minutes together and really making a difference between the progressions and regressions. You guys are listening right now, how much depth there is to these treatment plans and this rehab protocol. You can't do that with just 4 patients an hour. You can build that depth and that quality with just short time. So having this one-on-one time is just as important as coming into PT in general, right? So just make sure you get quality care wherever it is.
Awesome. Well, thank you guys for watching. If you're in this long, you probably have an ankle injury and you want to
Right.
learn. If you like this kind of content, let us know. We'll put more out about injury related stuff. Again, this was a masterclass. So learn, re-listen, understand what it takes for you to get from point A to point B. It's a process, but you can get there.